Welcome to Dr. CM Edcast, your go-to resource for medical learning. Through discussions, case studies, tutorials, and debates, we help you learn, grow, serve.
All right, let's dive into a really fundamental area of pharmacology. We're talking about laxatives. Now, these are drugs that treat one of the most common clinical problems out there, constipation. And understanding them isn't just about patient comfort, it's about grasping some core physiological principles. So, let's get right into it. So, what are we actually treating here? Well, the clinical definition of constipation is pretty straightforward. It's having fewer than 3 bowel movements per week. But, for the person going through it, it's all about the discomfort, right? It's the straining, the hard stools, that really frustrating feeling of not being able to, completely empty the bowel. To really treat this well, you've got to understand both the textbook definition and the patient's actual experience. Here's our game plan for today. We'll start by mapping out the major classes of laxatives. Then, we're going to do a deep dive into a prototype drug, which is the key to mastering the whole class. After that, we'll compare and contrast it with some other key players, see how to apply all this in different clinical situations, and we'll wrap up with a really important note on dependency. So, how do we actually go about managing constipation with medications? Well, there are really 4 main strategies, and each one has its own unique way of working. Let's break those down. The big 4 are bulk-forming agents, emollients, which you probably know as stool softeners, osmotic laxatives, and finally, stimulant laxatives. Each of these tackles the problem from a different angle. One adds mass, one softens things up, one draws in water, and the last one directly stimulates the bowel. Think of them as 4 completely different tools in your clinical toolkit. Now, if you really want to ace your pharmacology exams, the secret is to master a prototype for each drug class. So that's what we're going to do. We're going to take a deep dive into the bulk-forming agents, because once you truly understand the prototype, you pretty much understand the entire class. And our prototype for the bulk-forming class is Aspergillus husk. This is a perfect example. So when you see an exam question about, say, methylcellulose or sterculia, you can just apply everything you've learned about Aspergillus husk. The mechanism, the side effects, the monitoring, it's all going to be the same because they work in the exact same way. So how do these things actually work? The mechanism of action for bulk formers is completely physical. Our prototype, Aspergillus husk, is just a high-fiber agent. Think of it like a sponge. It gets into the gut, and it just soaks up water, which naturally increases the mass of the stool. This physical bulk then stretches or distends the bowel wall, and that stretching is the signal that stimulates peristalsis, the natural wave-like contractions that move things along. Now, a key pharmacokinetic point here is the onset of action. It takes 2 to 3 days. This is not for immediate relief. The side effects here make perfect sense if you think about the mechanism. Of course, you might get a sensation of fullness. You're literally adding bulk. If it works a little too well, you could end up with diarrhea and maybe even dehydration. But here's the dangerous part. If it's not taken with enough water, that spongy material can basically turn into a cement-like plug, causing a fecal impaction or even a full-blown intestinal obstruction. And that brings us to the most important exam pearls and monitoring points. You have to manage that mechanism. The number 1 counseling point is to take it with a full glass of water, at least 240 milliliters, to prevent that obstruction we just talked about. After that, you're just monitoring for the expected effects like diarrhea, checking hydration, and of course, always keeping an eye out for signs of dependence. Okay, so we've got a really good handle on bulk formers now, so let's use that as our foundation to compare them to 2 other major classes, the stimulants and the osmotics. They all have the same goal, but believe me, they get there in very different ways. Stimulant laxatives, like Senna and Bisacodyl, are way more direct. Instead of physically stretching the bowel, they act like a local irritant. They directly stimulate the nerve endings right there in the intestinal wall. This basically gives peristalsis a pharmacological kickstart to get things moving. It's definitely a more forceful and faster approach compared to the gentle nudge of a bulk former. Then you have the osmotic laxatives, like lactulose. These work on a whole different principle. These are substances that your body can't absorb, so when they get to the colon, they create this high concentration of solutes. And what does that do? It triggers osmosis, pulling water from the body right into the colon. The result? A softer, larger stool, which in turn stimulates peristalsis. It's just a different route to a similar outcome as the bulk formers. Okay, pay attention to this one because this is a classic high-yield drug interaction that you absolutely have to know for your exams. Bisacidil tablets are often enteric coated, right? That coating is there to protect the stomach. But things like antacids and milk are alkaline, which means they raise the stomach's pH. This can cause that protective coating to dissolve way too early, releasing the drug right in the stomach and causing a ton of irritation. This is a perfect example of a pharmacokinetics question. And here's another critical point, a huge contraindication for a specific group of patients. Castor oil is a really powerful stimulant laxative, but that stimulant effect isn't just limited to the bowel. It can also stimulate uterine contractions. And for that reason, it is an absolute no-go in pregnancy because it could trigger preterm labor. That's another must-know pearl.
Okay, so now we know the mechanisms, but how do we actually apply this knowledge in the real world? Let's walk through some common clinical situations and figure out which tool from our toolkit is the right one for the job. This table is a fantastic summary. For simple, run-of-the-mill functional constipation or in pregnancy, you want the gentlest, most natural approach. So you start with dietary fiber and bulk laxatives. If you have a patient who needs to avoid straining, like after a heart attack, bulk laxatives and stool softeners are perfect. Now, in an emergency, like a drug poisoning, you bring out the big guns. A saline osmotic laxative, which uses non-absorbable salts to create a massive osmotic effect and flush the system out fast. And for bowel prep before a surgery, you need something powerful and reliable, so you turn to a stimulant like bisacidil or an osmotic laxative.
Before we wrap this up, there is one last crucial concept we have to talk about that applies to all laxatives, but especially the stimulants, and that's the risk of dependency.
And this is the question every single one of us has to think about. With long-term use, particularly of stimulant laxatives, the bowels can actually become lazy. They can lose their natural muscle tone and their ability to work on their own. The body essentially becomes dependent on the drug just to function normally. And this is that tricky point where the treatment itself turns into a new and often much tougher problem. It's a powerful reminder that our goal is always to help the body restore its natural function, not to replace it.